Good afternoon or evening, everyone. Thank you so much for joining us today for this webinar on post-operative considerations when using the Meek technique. I want to thank you all for being here to listen to this lecture. We will dive into it a little bit later. First, we want to give people a chance to join the room. I want to point out that there is an opportunity to have subtitles in your lecture if you would like to have those. You can find that button at the bottom of your screen. So we will be talking on post-operative considerations. We've been expanding the business with the Meek technique worldwide, and a lot of the time, most of the time, we get questions. So what do we put on those gauzes and what do we put on the little squares, on the little islands? And that is something that we would like to address today. I noticed there is not a whole lot of people in the room. I see mainly my colleagues and a colleague from, I think, the Emirates. I'm not sure. So thank you just for joining us. I really appreciate it. And even though we are with not many, I think it's worth our while to just go ahead and do the presentation anyways, because where more people are together, there's always something to learn from each other. And I'm sure that that will happen today as well. So once again, there is if you need a translation, I'm not sure if we can translate to Arabic, but just bear with me with the English then. Later, we will go into the questions. If you like, you can answer, put all the questions in the Q&A. There's also a button at the bottom of your screen where you can post your questions. Just write them down in that section and we will handle those during or after the lecture. I will just go ahead and start this presentation and I will start sharing my screen. So post-operative considerations when using the Meek. My name is Fenike Tempelman. I think most of you know me. I'm a former burn surgeon from the hospital in Beverwijk, and currently I'm the medical advisor to Jamaica. We will dive into the features of the Meek gauze. We will talk about timing of dressing change and how often do we do a dressing change. We will talk about the different choices of dressings that you have, when to remove the gauze, and also a little bit on hypergranulation tissue. First of all, the features of the Meek gauze. The Meek gauze consists of a nylon, which acts as a non-adherent layer to your wound bed. So this nylon will not grow into the wound bed, and you can consider it your first layer, your non-adherent layer in your dressing. So there is no need to add an extra non-adherent layer for those features. Sometimes a non-adherent gauze like Gelonet or like Cuticirin or Urgutul are used for their moisture features. And in that case, you can obviously use it. But if you would like to use it as a non-adherent layer, then you don't need it because the Meek gauze has those features as well. The permeability of the gauze is good for wound fluid, less good for blood and slough. And with slough, I mean that discharge from the wound that together with microbes will give this kind of slimy discharge that will not run through this Meek gauze. So when do you do a dressing change? So the timing of the first dressing change would be on post-operative, as early as post-operative day 1, or at the latest on post-operative day 5. And the frequency of the dressing is really depending on the gauze as well as the preference of the team. However, when you do a dressing change, do not remove the Meek gauze. That is your lowest layer, and the Meek islands need to grow in. So leave that in place. When you remove the outer dressings and you all the way down to the Meek gauze, you can clean it with antimicrobial skin wash. In my clinic, we were used to clean those with soapy gauzes, and the soap consists of the soap that surgeons use when going into theater, so an antiseptic, antimicrobial wash, that you have to rinse with water and to remove all the soap rests. Also, the use of hypochlorite solutions is allowed. Some people use these solutions to clean the wound, which is obviously an option, and other people would use that hypochlorite solution to just spray the wound after the cleaning and then let that sit for 50 minutes before they put on the dressing. So that use of a hypochlorite solution on a meat gauze is allowed. So now a little bit more on timing of the first dressing change. You can go in early on post-operative day 1 or 2, and I would suggest to do that in case you are afraid of hematoma formation underneath the gauze, or if there is a high microbial count. And in case of hematoma, that might be the case when the patient is on anticoagulants, or if the blood pressure during the procedure is low and the blood pressure on the ward may be higher. In those cases, the chance of hematoma are higher. The frequency of the dressing is all got to do with the preference of the team, obviously the availability of the dressings in your unit. Also the type of dressing, silver-containing dressings, for example, can be left to the wound a little bit longer. If there's a lot of exudate, I would suggest to do more frequent dressing change, especially when the outer dressing are saturated. I feel you should change those outer dressings. When there's a high microbe count, you want to do a more often dressing change. And also if we are facing a microbe that might cause damage to your wound, in that case, I would do a dressing change more often as well. So you can go as often as once per day, or in case of a silver dressing, you can go for 5 days or 7 days. This is a picture of a hematoma underneath a meat gauze right here. And as you can tell, the blood will not seep through, and the skin islands are adherent to your meat gauze, not to the wound bed. So to improve graft take, you would have to cut this gauze and flip it over, remove the blood clot, and then close that meat gauze back on the wound. And this on the right-hand side is an example of a patient who had some blood punctures still there, but these were minimal, so there is no hematoma formation underneath this gauze. So this to me looks fine, whereas this needs to be addressed. So the choice of dressing, it's got to do with the availability of and the preference of the team, and you are aiming for moist wound conditions and infection control, or prevention rather. So when you aim for moist wound conditions, you want to avoid desiccation, the drying out of the wound bed, and you want to absorb the abundance of wound fluid. And this can be done by one of the foams that are in this slide. This is a foam that's a little bit thicker. This is a foam that contains silver, and this foam has a contact layer that is antiseptic. All these foams are absorbent wound dressings. So if there is a lot of wound fluid, you may want to choose to take one of these foams. So when you do a dressing change, as said before, you can use those foam treatments. I know of hospitals that use the nanocrystalline AG on top of the gauzes and then place GeloNet on top of that to keep it moist, and then use regular gauzes. Some people would apply an extra non-adherent layer like GeloNet or Xeroform or Adaptic with some gel or ointment when they feel that the wound might a little bit dry out. Some others are using ring outs with antiseptins of antimicrobials. And I know of hospitals that would use negative pressure therapy. On top of these non-adherent gauze with gel, for example, or on top of the nanocrystalline AG, you want to apply a secondary dressing to keep that all in place. And the choice of that secondary dressing really depends also on the amount of exudate on the wound. And there is two choices which I will come back to in a second. So when do you remove all these mucoses? You would remove the staples on post-operative day 5 or 7. By that time, your mucose will be a little bit adherent to the wound. It will not slide off. And if it does slide off, then it is probably for the better. And you finally want to remove that mucose between 5 to 7 days post-operative. You want to remove that mucose early when there is signs of infection, and I will show some cases with signs of infection later in this lecture. When the mucose is rather adherent to the wound bed, so it's not easy to remove from the wound bed, I would suggest to apply cream 12 to 24 hours prior to the removal of those adherent gauzes. So I would say remove staples on post-operative day 5 to 7 and remove the gauze after 5 to 14 days after application of a cream in case of a very adherent mucose. If you apply this cream, then the removal of those mucoses is atraumatic. And now we come back to the secondary dressing that you would place onto your dressing of choice to keep that dressing of choice in place. So for example, that non-adherent gauze or the ring outs that you chose. If you have a wound bed that is with a very high exudate, so there's a lot of wound fluids, I would suggest to use hydrophilic gauzes as shown in the pictures to the left. These hydrophilic gauzes, they kind of absorb all the abundance of wound fluid, and it also helps the evaporation of the wound fluid as well. So with wet wound conditions, I would choose hydrophilic gauzes. When there is rather dry wound conditions and you want to keep the moist in, I would suggest to use a cotton cloth, usually known as king's cotton. This is tightly woven cotton, which will not absorb. It's really like a cloth, and it will also not, it will diminish the evaporation from the wound bed. And the nice feature about these about this king's cotton is that these come in very large sizes of 1 meter by 45 centimeters. So I'm just metric. I'm not sure how many yards or whatever that is. I think 3 feet by 1.5 feet. So this is what a foam dressing would look like on top of meat gauzes. So the meat gauze right here of the foam dressing right here, you can see is rather saturated with wound fluid. You can tell there is meat gauzes underneath right here. And also the secondary dressings on top of this meat gauze or on top of this foam were hydrophilic gauzes, and these were all saturated. So we decided to remove those. And when we see a foam that is saturated as much as this, and we are like 3 days after the application of this, I would suggest to remove this, look at the meat gauzes underneath and replace or choose another one. If it's not as saturated as this, then you can leave it on for a little bit longer, up to, I think, 7 days. And this is just a patient with burning of the leg, and he is grafted with a MEEK1-4. MEEK1-4 really grows out really fast. The top picture is a picture of the legs just grafted, and the lower picture is of the leg about 5 to 7 days post-surgery. So in this case, we don't see a whole lot of wound fluid, so I think you can choose whichever you like. So if you use a foam, that would be able to absorb the minimal fluid that is here. That would be a fine choice. You could also go with a non-adherent gauze because the wound is not very wet. You can apply that and then place gauzes on top. So if you have a wound that is rather like moist already, you can just start with one choice and then look just examine what the wound will do to see if you are on the right track or not. And in this case, we chose ring outs, and this is what the wound looked like after 5 to 7 days. And this seems a little bit dry to me now, but the gauzes are kind of adherent to the wound bed. So in this case, because it is rather dry, we were choosing to go for a non-adherent gauze with a polyhexanide gel to keep that wound a little bit moist, but not too wet. We would remove the staples at this point and keep the gauzes in place, and then for the skin to grow out underneath these gauzes. And this is another example of what a wound might look like 5 to 7 days post-burn, of post-meek grafting. So this is upon day of excision, and this is about 5 days after grafting. And these wounds also look a little bit more moist than the others. Wound that I just shown you. So this to me seems fine. And these gauzes are kind of adherent to the wound bed. They do not slide back and forth. So that is nice. So the skin is growing in. At this point, I would start to remove the staples and then maybe apply a foam. That could be a choice. And you can also choose a non-adherent gauze as well. Because the wound looks rather moist and not wet. So you want to keep that moist in. You want to avoid that all from evaporating from the wound bed. So dry gauzes, in this case, I would not apply dry gauzes just on top of this. In that case, I would apply an extra layer of Xeroform or Gelonet or an iodine non-adherent gauze to prevent the little bit of wound fluid that is still in the wound bed from evaporating. In this case, we chose rather dry ring outs that we applied on her wound, and on top of that we placed the fixating dressings, and the fixation is done again by a cotton almost jersey to prevent those ring outs from drying out too much, because if the ring outs dry out, then your wound bed will also dry out. And in this case, we would apply new fluids to the wound bed in the evening. So these are ring outs, but not very wet, just dry ring outs with some extra dressing to avoid evaporation from the wound bed. So if you have these types of antiseptics in your hospital, that would be something that you could choose. So it could be PHMB solution or acetic acid, or one of the other ones mentioned in the slide. As said before, you can also use negative pressure therapy on top of your meek gauzes, and that is especially nice to use when the wound bed is not, if you are not certain about the vascularization of the wound bed. In that case, I would apply negative pressure to help evacuation of the abundance of wound fluid, and also to speed up the revascularization of the wound bed underneath your meek gauzes. So when that's the case, then please apply the negative pressure therapy as shown in the picture. Sometimes you need a little bit more suction than you used to, because we are working with large wounds. But I would only use a higher sucking to empty out all that air, to make it airtight, and then go back to a lower negative pressure of about 70, 75. And this is what that wound look like after the removal of the meek gauzes and the negative pressure therapy. And these are some examples of what a wound might look like after like 1 day or 3 days. And just to show you what is dry and what is moist. So these two pictures right here feel kind of dry to me, whereas this picture seems moist. So this is really what you are aiming for. And this to me is a little bit on the dry side. So if you have a case that with the gauzes that look like this, you can go ahead and just continue as you were, because you are doing it right. When the dressings look like this, I would go ahead and try to avoid evaporation from the wound bed and try to keep that moist by adding on an extra non-adherent layer or with some ointment or some gel. And you could even try as a non-adherent layer, a silicone layer with holes in it that also really brings down the evaporation from the wound bed. And I would try not to place any dry gauzes on top of this, but I would go for the cotton, the King's cotton, to minimize the evaporation from the wound bed. I know of some doctors that would use Acticoat on this wound, and that would also be a solution, as long as you make sure that the wound doesn't dry out too fast. And sometimes Acticoat needs that little bit of wound moist to keep it going. Avoid the Acticoat from drying out. And now we go on to this lady that we have seen before. So this is post-operative day 5, and this is post-operative day 5 as well. So this to me seems moist. This to me is leaning on to wet. Whereas with the previous picture, this is moist leaning on to more dry. The next picture, this is moist and this is moist leaning on to wet. So in this case, I would really want to know if the meat gauzes are tight to the wound, because if they are, then you're in the clear. If these meat gauzes are able to slide back and forth on post-op day 5, this means there is a lot of wound fluid still going on, and you want to make sure that your meat grafts will adhere. So if you look at this wound like this after 5 to 7 days, you may want to consider to start a drier wound protocol, or you may want to consider to remove these gauzes just the same. Because if the wound gauze, the meat gauzes are sliding back and forth after 5 to 7 days, there might be a problem of bacteria going on, of microbes. So, but if your wound cultures are clean, then this may also only be just an abundance of wound fluids, which needs a better dressing regimen. So, and it all depends on what do you see, what do you feel, what do you smell. That is kind of difficult to tell from a picture, but those are things that need to be taken into account when you choose your dressing. So if this doesn't smell and if the wound cultures are clean, then we are looking at just an abundance of wound fluid that can be addressed with dry gauzes, for example. But if the wound kind of smells and you have a positive wound culture, for example, for the Staph aureus, then in that case, there is more to this wound than that meets the eye. And in that case, I think I would opt to remove those gauzes to make sure that we get rid of those high microbe count. And this would be an example of very wet wound conditions in which I feel that the microbes are already leaning into from going from colonization to an infection. And we always want to prevent a wound from going from colonization to an infection. And in this case, when the wound is as wet as this, after 5 to 7 days, and you are able to slide this back and forth, I would definitely suggest to remove these gauzes and start your antimicrobial or antiseptic treatment, which we will come to later in this session. And this is an example of what removal of the meat gauzes would look like. So in these cases, most probably these meat gauzes are not very adherent to the wound. And if you can slide this back and forth upon removal of your staples, then you can just go ahead and try to remove this meat gauze when it's loose anyway. If you have rather tight meat gauzes to the wound bed, then you need to apply some kind of cream 12 to 24 hours prior to removal of these gauzes. So this comes in handy when the meat gauzes have been in place for 10 to 14 days. In those cases, usually the meat gauzes are rather adherent to the wound bed. And in that case, you want to loosen up that gauze by applying that cream. And then once you remove that cream and the gauze, then this is what the wound looks like. It's rather on the wet side, but this will be managed with your new dressing. And this is not as wet, so this is a drier wound conditions where you see that the meat islands all took very well, and we can then start to protect these meat grafts to help them to grow out. So these gauzes are removed I think 5 days after application. This is why you only see the little meat islands. If you keep the gauze in place for 14 days, in that case, you will see that along this island, around this island, there will be new skin that has grown out from the island. And in smaller enlargement ratios, the skin may heal completely under your gauze when proper dressings have been applied. So how do you protect those meat grafts after removal of the gauze? Well, you can just go ahead and keep on doing that foam treatment, because most of the foam have a contact layer to the wound bed that protects the wound bed, and so it will also protect your meat gauzes. And depending on how wet the wound is, you can either apply a cotton or hydrophilic gauzes just to get that wound going. You can also apply a non-adherent dressing to the wound bed. That could be for example, I know of a hospital that we use Surface Soft, that's that nylon type dressing, and they place Acticoat on top of that. I know of hospitals that use that same Surface Soft and use some ring outs on top of that. So there's multiple options. Another non-adherent dressing that is used often is just Jellonet, which is then frequent with a frequent dressing change. And I know also a lot of hospitals that use the Cuticirin or the Ergutil as the non-adherent dressing, or Adaptic, for example. Usually those non-adherent dressings do not have an antiseptic in it. Some of them have some silver in it. If there is, but I would suggest to use topical antiseptics on top of that non-adherent dressing. I know in Mexico they use matrix type dressings like Oasis on top of the meat islands. And I know also in Germany, people use the polylactate dressings on top of the meat islands as well. And last but not least, you can use the sandwich graft technique, which is allograft or xenografts placed on top of the meat islands. And I will go to some pictures. We've seen this lady before. We have seen the secondary dressing when the meat gauzes were still in place. And this is upon removal of those meat gauzes. And then you see a very nice graft take, a little bit on the dry side. And this is why we chose for a non-adherent gauze that has been, in this non-adherent gauze is our antiseptic ointment. And on top of that, we are placing that cotton gauze to prevent the wound from drying out too much, and then just a fixation dressing. And this is an example of the sandwich graft technique. Here is a person with a very high TBSA burns, and we see the little islands in this wound bed right here, and the little islands need to be protected, and it is done by allografts, and these allografts are applied by a non-adherent gauze that has been saturated with iodine, just a local antiseptic with broad spectrum against a lot of microbes. And this is a way to fixate that to the wound bed. These are allografts, and also xenografts can be used for these types of dressings, also known as Alexander graft. This is what that would look like 2 weeks after applying the allografts on top of the meek. You can tell the meek islands are growing out underneath. And in most of the cases, meek islands grow out underneath those allografts. And then the skin is pushed off, that allograft skin is pushed off by the patient's skin underneath. And this is what that looks like 5-week post-surgery and 5-month surgery. So at this point, he is at the peak of his scar formation. This was a very deep burn, as you can tell from the wounds that still exists on his tibia. And here is a nice case shown from day surgery till healing. So this is a deep partial thickness burn, so a deep 2nd-degree burn that has been grafted with the MEEK 1-4. And this is upon application of the MEEK gauzes. And this is on post-op day 2. I think we have seen this picture before. I'm sure it's familiar to you. And this is after removal of those MEEK gauzes on post-operative day 7. And in these MEEK islands grow out very, very fast, especially on a wound where there is some dermis left, then healing is really fast. So this was done with the MEEK technique to preserve donor site, to have a small donor site and fast healing of this large burn. Just for a pointer for you, there is some gaps in between the MEEK fields. So in this case, the MEEK gauzes were kind of aligned instead of the skin. Always try to avoid this, because this may give, in deeper burns, this may give hypertrophy of the scar. However, in this case, where there is a deep partial thickness burn, I kind of understand the choice. But when there is a deeper burn, you want to really try to align the MEEK islands to avoid hypertrophy of the scar in between the MEEK fields. So how to prevent wound infection? Well, we usually do wound cultures to find out what is going on in the wound bed, to prevent the wound from going from colonized to infected. That is what burn treatment is all about. You want to prevent the wound from deteriorating. And this is why we always smell, we always look at the exudate of the wound, and we always want to do wound cultures. Even I know that in a lot of countries, this is not very common, also because of the late results from wound cultures. In that case, you need to really run by your nose and by your eyes and by your touch to see if the exudate and the odor is changing. Because if it does, then your wound is turning from colonized to infected, and you really want to be ahead of that. You really want to be ahead of more pain and swelling, and that the skin feels warmer. You want to be ahead of hypergranulation forming, and especially ahead of graft ghosting, because all those signs of infection, I feel like we are running kind of late on changing our local therapy on those wounds. So this is what MEEK looks like on a nice wound bed. And this is MEEK on a wound bed that looks to me kind of disturbing. And the same goes for the mesh grafts in these pictures. And I just want to point these out to show you that you can address those MEEK islands the same as you would do a wide mesh or a more narrow mesh. Whatever your treatment you are used to applying on this mesh graft, you can use that same treatment for MEEK islands. Same goes for a mesh graft with a higher expansion ratio and meek islands that look like that. And we come back to the permeability of the meek gauze. I've shown you that hematoma will stay underneath the meek gauze, but also slough from microbes. That is shown in these pictures. You see that underneath these meek gauzes, we see this kind of yellowish wound discharge. And this to me seems a little bit disturbing, especially because it seems like these dressings, these meek gauzes, are not adherent to the wound. So what you want to do is cut this gauze and then manually try to remove that slough from underneath these meek gauzes, as well as here. And you should try to remove this, especially on the first couple of days after the procedure. So this is why, in case of you feel that microbe might be a problem, in that case, you want to go in early and not wait for 5 days until first dressing change. If you feel that microbes might be a problem, go in early to be able to remove this for the skin islands to be adherent to the wound bed again. And I know of some doctors that will make cuts in the meek gauze to allow that discharge to seep from underneath those gauzes. So that might be a choice. And this is just the start of that same slough. I would want to remove that to prevent it from spreading from under this gauze. So just a little slit on top of this, manual removing of that, and then make sure that you're getting rid of all of this. And this is a case of graft coasting. Well, we have seen this picture before. As said, this seems really wet to me, especially when this is on post-op day 5 or 7. It needs to be a lot more moist than this. And the gauze is really not too adherent to the wound. So you want to remove that. And then what you see is that it seems like there is no islands in this wound bed. But if you look very close, which is kind of difficult on top of your screen, but you see some little islands are still there, right here, right here, right here. So all the kind of dull spots in this wound is skin, but some of it seems overgrown by the granulation tissue. And you need to address this granulation tissue for the skin to be able to heal. So between this and this, there's no extra grafting. So there's no regrafting of this wound. It's just a change of dressing regime. So another dressing protocol to go from here to there. Oh, I'm sorry. Go back to this. There we go. So infection prevention. I know in a lot of countries, people do regularly wound cultures and also of nose and throat and perineum to make sure that they always know what is going on. If you are not able to run that regime or that protocol, always, I think you maybe need to have a little bit of higher dressing change frequency to be a little bit more ahead of your game because you do not have your cultures to back you up. If patients have certain microbes in their wounds, you want to quarantine those. And I know of some units that will decontaminate the nasal cavity because a lot of patients have Staph aureus in their noses, and those might contaminate the wound. So I know of hospitals that will decontaminate the nasal cavity just to be sure that there is no Staph aureus blowing over the grafts. So what is hypergranulation tissue? Well, this is overgrowth of fibroblasts and endothelial cells that form an excess of granulation that is above the surface of the wound bed. And when are fibroblasts and endothelial cells pulled into the wound? Well, that is in the inflammatory phase. In the inflammatory phase, products of the wound healing are in the wound bed, and those products will kind of adhere or call the fibroblast and the endothelial cell to come to the wound to start revascularization and also to start granulation formation. This is something that you want for normal wound healing. So a normal inflammatory phase is fine. We need that to go to the next phase of healing. However, if there is a lot of chemotaxis from fibroblasts as well as endothelial cells, if that goes too high, then we get the hypergranulation tissue. So when there is an excessive inflammatory environment, more fibroblast, more endothelial cells will come in the wound and more granulation is formed. So it's like an overproduction. So when do we have excessive inflammatory environment? In case of a high bioburden. So when there is a lot of microbes in the wound, there is a prolonged immune response, so a prolonged inflammatory response. Also, when there's allergens in the wound bed, and some dressings have detergents in the wound, in their dressing, and that may cause like a sensitive reaction from the patient. Occlusive dressings, in that case, the wound is too wet, there is less evaporations, and the wetter the wound environment, the more chance of hypergranulation tissue. And also occlusive dressings cause hypoxia of the wound because of the oxygen from the air cannot really come to the wound. And in that case, more endothelial cells are drawn into the wound to provide better opportunity to form neovascularization to get that oxygen to the wound bed. So in case of occlusive dressings, hypoxia may enhance the inflammatory response. And also friction, shear forces on the wound bed will cause inflammatory response, and in this way, hypergranulation tissue. And we will go to some examples of that. If we have granulation tissue as much as this prior to the Meek grafting, you want to remove this hypergranulation tissue and then place the graft on a clean wound bed that looks like this. So the peach kind of color that is kind of tough, fibrin-ish, instead of that hypergranulation tissue right here. In this hypergranulation tissue, there's a high probability of a biofilm of certain microbes, and you want to really get rid of that. Well, once the Meek gauzes are on, you want to control that inflammatory response by controlling the exudate, because remember, the wetter, the more granulation formation. You want to remove those Meek gauzes when problems arise, and you can leave the wound open to dry to get that exudate down, to get the wound drier, to have that formation of granulation diminish, and also to have more oxygen to the wound bed. Also avoid shear forces and make sure to control your microbe count and control inflammation. And this is an example of exudate management, because this is a more dressing issue more than anything else. We have a Meek gauze right here, and there is Meek gauzes under these non-adherent gauzes. I mentioned way in the beginning of this presentation, we were talking about how your Meek gauze is your non-adherent gauze, and that you do not need to apply an extra non-adherent layer for those features. If you feel that the wound bed is moist enough, you do not need to place this extra non-adherent layer, because if you do so, then there might be too much of the exudate will be underneath the gauze. There will be an inhibition of the evaporation of wound fluid. And this is shown right here, because this is where that dry Meek gauze is, or the moist Meek gauze. And this whole area right here is where those non-adherent gauzes was, with the excess of exudate underneath the Meek gauze. You can tell right here, this is kind of wet, and this is exactly this area right here. And there's Meek Islands right here, and those are the Meek Islands right here. And then we have this kind of more dressing here, and we see that area right here. So do not apply any non-adherent gauze in case of kind of wet wound conditions already, because that will pose this problem. And then this is what shear forces look like. We have on this shoulder, this is the back of a patient. We are looking at the back side of his right shoulder, and this is the enlargement of that. And we see skin islands in here, right here as well. And due to the shear forces, there's abundance of hypergranulation. And if you try to get that shearing go down, then these Meek Islands will reappear. And also you need to address this hypergranulation for it to diminish, and then the skin islands will grow out. So what can you do to minimize hypergranulation? It's using antiseptic agents like PHMB or silver aerosol, which is like a hyperchloride solution. You can use DACC, which is also a chloride type of dressing. There are some dressings that have this as the contact layer to the wound bed, and also you can use polyhexanate gels or fluids that are very good, especially against gram-positive cocci. In some countries, people are still used to applying dressings according to cultures. And this is especially in the case where there is not a big problem with multi-resistant bacteria. And in those countries, people still use antimicrobials to treat their microbes in the wound. For example, for the streptococcus and the staphylococci, they would use bacitracin, fusidinic acid, or furacin. And for gram-negative control, usually people use silver nitrate and acetic acid. And in the early days, and I'm not sure if they still do, they would use silver-myelin or mevanite on top of those. And always alternate these products to prevent overgrowth, because sometimes if you treat one microbe with a certain antimicrobial, then the other microbe might grow out even faster. So alternate products if you feel there is more microbes in a wound bed that needs to be addressed. And do not use these dressings for a long time to prevent resistance to these products from building up. To control inflammation, as soon as you feel that your microbe is down, you can start using corticosteroids every other day. And this inhibits the influx of the fibroblasts, so it inhibits the granulation forming. And avoid allergens. I know there are some dressings, for example, Adaptic has some detergents in it. This is not a problem at all unless a patient is sensitive to it. So if you feel that for some reason you cannot get the inflammation to go down, this might be the case that your patient is sensitive to the dressing, not allergic, but sensitive. So it may help you to change your non-adherent gauze to a different kind. So like an alternative for Adaptic would be Cuticerin or Ergotul or Sulfasoft or Meptel, or in case if you've been using one of the other products for a long time, you could switch to Adaptic. So just try to switch your local, so your non-adherent gauze if you feel that you cannot get the inflammation under control, because for some reason, some patients get sensitive to their dressings. We have seen that not very often, and it's always the last thing you think of, but hopefully with this, it is something that would help you. And then some random tips. I know of hospitals that would use hypertonic saline to get the granulation down. I know of hospitals that use a combination product of an antimicrobial as well as a corticosteroid, terocotril. And I know of hospitals using honey, which is very nice to get that biofilm down. I know of hospitals that use ozone in the very, very difficult cases. And in case of this patient, if the patient is going to theater for another procedure, then in that case, you may want to try to do some low Versajet or hydrosurgery on low power on these grafts. Like I would put it on 2 and then try to get that hypergranulation removed for the skin to be able to grow out again. I'm not saying bring this patient to theater, but if you are in theater anyway, this is an option that you could use when treating this hypergranulation. This hypergranulation can easily be treated by one of the previous mentioned non-invasive treatment as well. And I know of a lot of hospitals that would, after, as soon as they have that hypergranulation tissue down, that they would apply allografts or xenografts to prevent that allograft, granulation tissue from forming in between the little islands. And this is, to sum it all up, this is a case. We have a patient with a MEEK 1-4 on his back and then a MEEK 1-6 on the rest of his back. This is a patient that went very well, had a very good take on post-op day 7, but then in post-op day 14, they came into problems. And they have been using hypochlorite solutions up until now. And this patient was really moving back and forth in his bed. So there's also a problem of shear forces. So they decided to switch to a silver nitrate solution. And this is after 1 day of silver nitrate. And you can really tell that the wounds are easier on the eye. There is not as red as the prior pictures. And you can tell there is some skin already reappearing right here. So they kept on using that silver nitrate solution up until post-op day 29. And then they switched to corticosteroids, not only, but just alternating with an other local antiseptic. And they did that regimen until closure almost. So this patient has not gone into theater after that post-op day 14 that you saw, and this is on post-op day 36. So the MEEK islands are very resilient, and MEEK islands will grow out if you get your hypergranulation or your granulation tissue under control. And there's many ways to do that. And this patient just shows you what proper dressings can do. So your MEEK gauze is your first layer of the dressing. It's your non-adherent gauze. So do not use any other non-adherent dressings for that reason. Many dressing options, depending on the exudate and the microbes, try to keep it moist, not wet. Remove the gauze, depending on the wound condition, as early as post-op day 5 up until post-op day 14. And hypergranulation is really a problem of excessive inflammatory response that you can tackle with the different options that have been mentioned. I know this is one of the longer presentations, and I thank you for bearing with me all the time. I just want to stop sharing my screen, and I'm wondering if there's any questions in the room. So I will check it, and it seems that there is no questions in the room.
No, indeed, Fanneke. There are no questions.
I really want to thank you all for being here, especially my colleagues. Thank you, Aaron. Thank you, Caitlin, for joining us today. And then the dear doctor, thank you, colleague, from joining us from the Emirates. I really appreciate you being here. And please send us any message if you feel like we have not addressed everything and that we left out some information that you needed. Please get in touch with us. So this lecture is recorded. Make sure to get a copy if you want so. And the next presentation, the next webinar will be the 13th of February. It'll be done by Karel Klaas. He's a plastic surgeon from the University of Ghent in the burn unit over there. So thank you all for joining us. today, and I hope to see you real soon. Thank you, Aaron. Bye-bye, Caitlin.